First of all, I want to thank everyone for joining us tonight. Just to give everyone a quick introduction, so I'm Sri Komanduri. I work at Northwestern University. I also help lead the medical advisory board for EndoscopyNow, and really what has been an initiative that we're pushing forward, really around a series that we're developing for trainees. And as you kind of read a little bit, this is very different than a traditional, but you'll find lots of components of a traditional lecture. But the real focus here is we're looking at novel innovation in gastroenterology. And you'll see that what we've done is created what's called a clinical practice model, which really is about the nuts and bolts of implementing innovation in practice. So when you guys get into practice, as you move on into the real world, how do you take all these amazing innovative tools, devices, different things that we'll use, even drugs, and how do you implement them into clinical practice in your new? And I think those are things maybe you don't see all the time, and this will include a range of things, not only the data, the technical side, and how to do the procedure well, but also, really, what to use this, how to use this effectively, how do you interact from a multidisciplinary nature, and you'll see some of the KOLs on here are not just gastroenterologists, but oncologists for the specific event, all the way through things like reimbursement, going through a value analysis component, all the stuff that you'll do as you get into practice. So this is hopefully a very refreshing and a new way to look at things. And with that, I do want to hand the microphone off to our leader tonight, Dr. Neil Sharma, who will introduce our KOL team and be the MC of ceremonies here. We welcome you to tonight's program. And with that, I'll hand it to Neil. Thank you very much.
Thanks, Rudy. I appreciate it. I appreciate everyone tuning in this evening. We've been working on this project to hopefully engage and perhaps educate all of you on what we think is a very exciting therapy for dysphagia management and esophageal cancer, a very specific topic, but a topic that I think we can really have a high impact on these patients who have some significant issues and comorbidities related to a devastating disease. So we're going to talk to you tonight about a clinical practice model as the framework for our discussions. We put this clinical practice model together, and when I say we, it's all of the key opinion leaders who are on this evening. So I'm going to switch this over and forward here. So clinical practice model is really a playbook. And, you typically are used to seeing things like guidelines or expert opinions. This is perhaps a blend of both, but it's really meant to be practical. So what it's trying to do is encompass clinical and best practice approaches that are operational, but also engage in the technical skill set that's needed in order to be able to perform a particular procedure or to treat a disease state. So in this case, that's dysphagia related to esophageal cancer. This is a new way of us approaching creating a practical, basically algorithm or guideline or some sort of a policy in which you can refer to utilize in your basic clinical practice. And so that's where a lot of this conversation will be engaged around, and that's what you'll see the framework of tonight's PowerPoint. So I want to introduce the team. Almost everyone was able to make it this evening. Tuvik Hashami, who could not be here, is with City of Hope. He's a chief of staff and an interventional endoscopist. Shivandi Kothari, she's at University of Rochester, also an interventional endoscopist, an expert in cryoablation. Tilak Shah, who I believe has joined us, or perhaps has not been able to join us yet. He's at Cleveland Clinic. He's also an interventional endoscopist and engages in a large cryoablation practice. Jeremy Barber, who I can see is on the line. He's an interventional endoscopist with Corewell Health in Michigan. And then we have two medical oncology experts. As you'll see tonight, it's really important to engage with our medical oncology colleagues. We really do this in a multidisciplinary approach. I'm grateful for their participation, both this evening, but as part of this KOL team in the creation of the CPM. And that's Ravneet Bauja as well as Madhapa Kandranda. And Ravneet is at McLeod Health, and that's in South Carolina. And then Madhapa is at Banner, and that's Banner MD Anderson in Phoenix. So we're going to do a little bit of a multidisciplinary review of how we approach spray cryotherapy and dysphagia of esophageal cancer. Our goals of the session are to evaluate current utilization and efficacy of spray cryotherapy, establish operational kind of best practices for our patients in order to be able to select the right patients, execute the procedure, and execute it with a great margin of safety. Then identify some future research directions, which we'll touch on in the last slide. So just very opening section before I turn it over to our other KOLs, we're going to talk about how to manage dysphagia from esophageal cancer. So dysphagia significantly impacts the quality of life in esophageal cancer patients. This has been recognized by ASCO, which is American Society of Clinical Oncology, also by the American College of Gastroenterology, and also by the palliative care guidelines, which were updated last year at GI ASCO, which meets every year in January. And as you see, the biggest complaint or symptom that's really felt by these patients is dysphagia. And of course, that affects their nutritional status, which can impact their ability to get additional therapies. So in the past, there are different ways that we've approached this. And going from left to right, that's esophageal stents, radiation therapy, and PEG tubes. I'm sure all of you have had some exposure to this. If you've not, I think this is something you will see during your fellowship, and you'll see how we approach these patients. There's also the new kid on the block. However, as you'll see tonight, it's not that new. There's quite a bit of therapy around it, which is spray cryoablation. So esophageal stents, what are the pros and cons of esophageal stents? The typical complication that we used to see in the past is migration. In some of your programs, you may already have moved to suturing these fully covered metal stents, which are self-expanding stents, in place. Tissue ingrowth typically doesn't happen within the stent itself, but it can happen above the stent when it's fully covered. If it's an uncovered stent, you will see tissue ingrowth, and then occasionally perforation. But certainly the most common side effect that we see is pain and reflux, or symptoms due to reflux, especially if you cross the GE junction. Once in a while, patients may present with food impaction, though we see it less often with large caliber stents. There's been some advancements in these therapies. I mentioned in particular suturing the stents in place, which reduces the migration rates, which in the past have been reported to be as high as 40%. And then there's, of course, the ability to do some re-intervention should there be tissue ingrowth. Radiation therapy, most patients are getting this in a neoadjuvant fashion, meaning that after they've been staged, if they have T3 esophageal cancer or nodal disease, they're often still getting radiation. Some centers have moved to chemotherapy only. They utilize a different type of chemotherapy, which is called FLOT, F-L-O-T. What happens to radiation therapy is they do kind of a wide field IMRT approach of radiation across the esophagus and the surrounding nodes. This allows for symptom relief in terms of the luminal obstruction that occurs, but it can take a little bit of time. And in the beginning, they can get some exacerbation of the dysphagia because, as you can imagine, there's inflammation and esophagitis that's occurring as the radiation is taking effect. And then finally, PEG tubes. I'm sure all of you have or will be putting in PEG tubes quite a bit as GI fellows during your standard GI fellowship. There is a risk of infection. That's usually the most common complication on the skin of PEG tubes. Potential of tumor seeding, particularly in squamous cell carcinoma, if you're dragging the PEG tube through the area. If you're doing a push type approach or a Russell PEG tube, then the tumor seeding is eliminated. And then, what's most important to all of us is to make sure our patients have optimal quality of life. So because they have a PEG tube, yes, they can get nutritional status, but that doesn't mean that they can swallow and enjoy having food by PO intake or having food with family members and things like that. Also, sometimes, if it's very severe, they can have issues with management of secretions or aspiration with PEG tubes. So it's not necessarily the best long-term solution when you're accounting morbidity for the patient. So we talked a little bit about stents. You can see here that they're excellent for alleviating dysphagia. They will occur fast, right? So faster than radiation, perhaps faster than spray cryotherapy. They're immediately going to feel within the first 24 hours that their esophagus is more open. Now, we talked about what some of the adverse events are. There's low major adverse events. I'd say perforations are rare. There's a variable degree of what we call those minor adverse events, the biggest ones being, as I mentioned, chest pain or reflux symptoms, which can be as high as 50% of patients. Radiation, you get dysphagia relief in at least 80% of patients, if not greater. We talked about acute side effects that can occur. And then finally, some severe late side effects. So rarely, but once in a while, we'll see fistula formation, radiation pneumonia, or once in a while, stenosis. I'd say, again, those are less common, just like the major adverse events with esophageal stenting. So what about spray cryotherapy, or SCT? So this is an approach that allows us to deliver liquid nitrogen that's been super cooled to negative 196 degrees Celsius. As it does that, it freezes the tumor, and then the cell death occurs during the time in which the tumor thaws. And we'll get into these details a little bit later. It has been approved by the NCCN guidelines, which is the National Comprehensive Cancer Network. So if you've not been exposed to those guidelines, it's worthwhile to look at those. Advantages over traditional treatments would typically be that this is a non-mechanical tumor ablation. So that means that the patients don't necessarily get the chest pain that they do get potentially with stenting or radiation, less side effects in typical stents and radiation, and fairly rapid symptom relief, though perhaps not as rapid as stenting, but certainly more rapid than radiation. So it kind of fits into a nice category for us in our total algorithm for treatment of these patients. And here I've mentioned some of these aspects of the evidence and the value of spray cryotherapy. When we talk further about evidence, I mentioned this is not new. So now there have been multiple multi-center prospective trials. Your KOLs tonight have been involved with numerous trials that have been mentioned here. And we tried to highlight 4 of these trials for you, which I won't go through all of the details. But what's important that we're seeing here is that in all of these trials, we're able to continue standard of care, which is systemic therapy given by the medical oncologist. Patients are all getting significant relief of the dysphagia. And when quality of life is assessed on validated scales, these patients have significant improvements in their quality of life. So this modality does work. It works with high level of evidence. And when we look at the end target of dysphagia, it significantly improves patients' dysphagia while not compromising their ability to get standard of care therapy. So we added this case. This case will demonstrate. So those of you as fellows who have never seen spray cryotherapy, I'm going to walk you through a case of what this looks like. Video up. And I'm going to turn the volume off and I'll talk to you about, the steps of the procedure. I think it's worthwhile to also highlight the steps of the procedure. Later on, Dr. Kathari and Dr. Barber and Dr. Shah will talk to you about some of the details around how we deliver this therapy, but you'll get initial exposure here. So this is a patient with T3N1M0 adenocarcinoma of the esophagus, got chemoradiation, was not a surgical candidate, and ended up having some residual disease. Did have PD-L1 expression, which allowed for immunotherapy. We see that in approximately about 40% of these patients with esophageal cancer. We reviewed the case at our multidisciplinary tumor board. This is actually my patient. And we saw that the patient had persistent localized disease on PET scan, on upper endoscopy, and endoscopic ultrasound. Dysphagia was progressive with a high Eckhart score being 8 out of 9, 9 being maximum for an Eckhart score. So we decided to pursue cryoablation while the patient was on immunotherapy. So a little bit about the mechanism of action of cryoablation. I recognize you're all fellows. You may have various exposure. Really, we're using ultra-cooled liquid nitrogen, which is delivered at negative 196 degrees Celsius. What happens is it freezes the tissues, and as the cells thaw, they get direct cell injury and then apoptosis. What happens after that they thaw is that the cellular matrix itself is preserved, and we know that there's minimal scarring and normal tissue regrows. In fact, you can biopsy after doing spray cryotherapy, and pathologists can give you a great assessment of what the cellular architecture looks like without the compromise that you might see with thermal energy, which would actually denature those tissues, proteins, and histologic architecture. You have a big console here. The console has liquid nitrogen inside of it, and then spray catheters that you saw there on the screen, and decompression. Decompression is the key. For every 1 ml that you're delivering of liquid nitrogen, as it expands to a gaseous state, it's 700 ml. So this needs to be evacuated. So we have these decompression tubes that go through the mouth. The 2 black lines that you're seeing there go just past the GE junction, and we attach it to active suction. It's a fenestrated tube. 16 French is the preferred size, but there has been 20 French in the past. We identify the target. We then, after we've placed suction, we'll place the catheter into the working channel. And again, we'll get into the details of some of the specifics of what we'd recommend to get the optimal treatment. After that, catheter is into the working channel. We'll clear the working channel prior to that placement. The scope is in place with a distal cap at the end of the scope. We'll pass the catheter down. The catheter's on defrost as it goes down. And then we find the target area. We spray the target area. We start the timer after that entire target area that you're seeing on step 5 has become totally white. We typically, for malignant lesions in our studies, have used 30 seconds by 3 cycles. So it means 30 seconds of freeze, 1 minute of thawing, and then 30 seconds again. We do that 3 times over. After which time the decompression catheter is removed, the patient goes back over to recovery. Once in a while, we may do a dilation if the area is extremely narrow. Patients typically don't have a lot of pain with this procedure because, as you can imagine, the area is cooled off. And we'll get into some of those details again later on. So there are some tips and tricks. Again, we'll highlight these later. So I'm going to go through this rather rapidly so you can see what happens with the case. When it comes to application, that is important, and you'll see that highlighted here. We typically use a cupping technique. Remember, this is a non-contact therapy. So if you actually have contact with the catheter, it can actually freeze or stick in place, make it a little difficult to move. So we typically use a cupping technique whereby you're rotating or torquing the scope 180, 180 to be able to cover the area. We never start the timer until it turns white. We defrost the catheter as it's passed down so we don't get any ice balls on the catheter. And if the area is very narrow, we can use a neonatal scope, or as you'll see in this case, we can sometimes dilate. We recommend that for people who have had some experience and we would consider more advanced users for spray cryotherapy. Dosimetry is important. So if we increase the number of cycles, we typically won't do more than 3 cycles in one session, but as you saw, we can even do 2 cycles. If we increase the duration of the cycle, so 20 seconds, 30 seconds, or even 45 seconds for malignant disease, and then the time between treatments. So if you bring someone back 4 weeks, that's not going to be as high dosimetry as you bring someone back in 1 week. So here's the initial examination for this patient. And what you'll see here is I have a distal cap on the end of the scope, and I'm not able to actually pass. And I tried to kind of wiggle the scope and move through, but this looks like the diameter of the lumen is less than 10 millimeters. The scope itself is around 8.8 to 9 millimeters. So we take the cap off, we do our examination. And this is important because I need to define the GE junction in order to be able to pass the catheter distal to the GE junction with those 2 black lines of the catheter down into that area. That catheter that I'm speaking of is a decompression tube. And then once that decompression tube is just past this distal area of the esophagus, past the GE junction, we know that we'll get adequate suction, then we can deliver therapy. So you can see this tumor involves 360 degrees of the circumference, which is something that we like to note, as well as almost 90% occlusion of the lumen. So I kind of work my way through this area without the cap and then complete my entire examination. I think that's really important, right? You're looking for major ulcerated areas, areas of compromise, after which time I will drop the wire after I've completed my exam. This can be any sort of wire. Here I've used an 035 JAG wire, which we use for ERCP. And then with the cap off, I pass the decompression tube. And again, I want to make sure that these 2 black lines that you're seeing here are just past the GE junction. So we define that as the distal extent of the squamocolumnar junction, as well as the 2 gastric folds. So it's just past the upper aspect of the gastric folds. I do that air syringe before I actually put the introducer into the channel, just to blow out any saliva that may have gotten into the channel of the scope. Why? Because you'll see when you do these procedures, the scope gets very, very cold. And then we apply the spray. And here you're seeing application of the spray. And this is that cupping technique. So we really don't want to make contact, right? Because it will spray and it'll basically freeze onto the actual tumor itself, and it makes it difficult to move. So you're seeing kind of a nice even distribution. And we typically go distal to proximal. And as we cover this area, after the cycle is completed, we always have a standardized 1-minute thaw period. So here you're seeing the cupping technique, the entire area getting whited out. So just remember what it looked like in the beginning, right? Barely past the scope, even without the cap. And as you'll see at the end, there's a remarkable response for this patient. So as it thaws, don't be surprised if you see bleeding. That's typically what we see. We want to see hyperemia and bleeding. Post-ablation, we decided to dilate this patient because they were less than 10 millimeters in size. So we performed dilation in order to expedite recovery from dysphagia. And so we used a CRE balloon catheter to do dilation. Again, this is a more advanced technique, but the fact that the histologic and extracellular matrix has been frozen, it makes it more adept to perform dilation. If you perform standard balloon dilation without freezing, as you know, these tissues are very compliant and the tumor will just bounce back in place. There's really limited efficacy of doing that. But because we've frozen these tissues, we've adapted them, and it allows for us to have more efficacy with dilation. And this has even been shown in benign disease states by Jason Sammarcina in some pilot trials for benign esophageal strictures. So here we're dilating. We typically use the rule of 3, so I'm not going to go more than 3 millimeters bigger than the original lumen. We hold the balloon for a minute. It's a bit of an arbitrary number, but we'd like to make sure that it's getting the response that we would expect, and that frozen area is now being opened up. And then as you'll see, the lumen, when we leave the patient, now it's easy to pass the scope through, and it's quite open as opposed to being completely compromised. So we're passing the scope without any resistance. So almost immediate response to cryoablation. we're going to build from these basic principles as we go through the lecture. So I'm going to turn it over to Tilak, Madhapa, and Ravneet, who are going to talk to you about timing with systemic therapy. Dr. Kundranda, I believe this is your case.
Thank you, Neil, for setting this up. Yeah, like Neil mentioned, I'm a medical oncologist, a GI medical oncologist. And I think one of the key parts to, before we even start this case, the perfect way, segue to this case is as trainees, I think it's important for you to recognize within GI malignancies how when we look at the subspecialties coming together, gastroenterology is that integral part of any multidisciplinary team. I mean, when we think about the three legs of a stool of oncological care, right? Rad-onc, med-onc, surg-onc. GI in GI malignancies, gastroenterologists in GI malignancies, both advanced and non, are an integral part of that fourth leg of that stool. And hence this collaborative, hence having these collaborative discussions, but also the whole point of being able to have these conversations with your oncologist is going to be critical while you guys finish your training and then go on to real practice. And this is a perfect case of this collaborative effort. If it weren't for my gastroenterologist, and while I walk through this case, you'll see how this would have probably just been a very different run-of-the-mill case, and the patient would not, the outcomes wouldn't have been as dramatic. Just a brief history, this was a young male who had presented, and not an uncommon presentation of dysphagia or dynophagia, mainly to solids of about a 6-month duration. So as with everything else, a CT of the chest was done, which demonstrated circumferential mass in the distal esophagus with some lymphadenopathy that was noted. So an endoscopy was performed, and at the EEGD, what was noted was a large obstructive mass in the distal esophagus. G junction, the epicenter was not commented on. And again, just switching gears, epicenter for us as medical oncologists, and even for you guys, when you comment on that, it becomes critically important, because when we look at the way we treat G junctions and we break them down into SUERT 1, SUERT 2, and 3, SUERT 3 is treated very differently as opposed to SUERT 1. And 2 is somewhere in between in the context of what we would decide in terms of upfront therapy and management. Nevertheless, the patient was noted to have a moderately to poorly differentiated adenocarcinoma and then presented to us. So as with most of these cases, one of the things that we automatically do as part of the workup staging is to have an endoscopic ultrasound. And this was endoscopically staged as a T2N2 with multiple peri-regional lymph nodes that were noted. PET-CT to complete the staging unfortunately demonstrated multiple non-regional lymph nodes, including the supraclavicular space, paraspinal space, and the retroperitoneal lymph nodes. In esophageal adenocarcinomas, PET positive non-regional lymph node, even without a biopsy, is still considered stage 4 unless you have an alternate reason for those lymph nodes to be FDG avid. So at that point in time, the patient, now we had this patient with what we would clinically stage as a stage 4 metastatic adenocarcinoma of the G junction, and then was seen in the medical oncology clinic. This was in 2017. So in 2017, we still hadn't had our data with IO therapy being other than on clinical trials, when we weren't using it up front in these patients, and we'll get to that in a second. But nevertheless, I think the key part was to stop the patient on a backbone chemotherapy while we were waiting up for the molecular profiling. And at that point, the main, in 2017, what we were mainly looking for was based on the TOGA study, using an anti-HER2 new agent in patients that have a HER2 new amplification, which is about 20 to 30% of patients with GEJ gastric adenocarcinomas. Nevertheless, so in those cases, since the profiling takes a couple of weeks, and it can be as long as a month, we tend to stop the patients on chemotherapy and then add additional agents based on the profiling results. In this case, the patient's tumor was positive for HER2 new amplification, and hence the patient was started on trastuzumab in addition to Zelox, which is Xeloda, which is an oral chemotherapy drug, along with oxaliplatin, which is a platinum. So Again, 2017, January of 2017. And as we have recognized with traditional chemotherapy, the duration of therapy really depends on cumulative toxicities in addition to response. So once you're having response, the rate limiting factor there seems to be the cumulative toxicities. And with anything which is platinum based, usually it's about 4 months or so when we start seeing these neurotoxicities with neuropathy and the like. Not surprisingly, the patient had a great response. And then at that point, with some underlying neuropathy that the patient was developing, the patient was de-escalated. I apologize, the arrows here did not come through. Was then de-escalated to capecitabine, which is a nodal chemotherapy, fluoropyrimidine, with trastuzumab. And then after about 6 months of therapy with excellent response, actually almost had a complete PET response, the patient was switched to just single agent trastuzumab. And then fast forwarding to about a year and a half later, this patient started developing dysphagia. And at that point in time, a PET CT was performed. As you can see, again, the arrows didn't come through. So at baseline, the patient had an SUV of 60 prior to us starting therapy. And at the maximum response, he nadered at about an SUV of 6 in the distal esophagus. And in November of 2018, what we noticed was the SUV was starting to go up to about 14.5, and then obviously was having clinical dysphagia. So at that point, we escalated therapy back to, I still had some underlying neuropathy, so escalated therapy back to the fluoropyrimidine plus the trastuzumab. And the key part here was none of the lymphadenopathy, the non-regional lymphadenopathy, or even the periesophageal lymphadenopathy lit up, and it was mainly uptake within the esophagus and dysphagia. So that was the time wherein I reached out to Dr. Kashami, and we've had several of these patients, and this is a perfect example of this, wherein the options there were multifold. One, we could have gone with the traditional thing of saying patients having dysphagia, why don't we just place a stent in, let's escalate therapy and see what happens. The second option is chemoradiation, like Neil mentioned. And then the third option is the other ablation techniques or the like. So given that the patient had never had chemoradiation in the past, one of the things that we discussed was, given that it was local therapy, and given that the patient had never had local therapy, one of the considerations was to consider spray cryotherapy. The first picture that you see on the left side was at baseline when the patient had significant amount of dysphagia. I continued on with the capecitabine with the trastuzumab, and then 6 weeks. So basically, every 3 weeks was when the patient was getting spray cryotherapy. What we would do would be to time it so that my chemotherapy regimen was Q21 days. So I would have Tawfiq probably do the procedure on day 18 or day 19. And Xeloda is typically given for 14 days. So at that point, the patient's not getting any therapy. And then we continue to do that. And as you can see, this was, I think, at about 6 weeks, I think, is the first one on the right side. And then the one at the bottom left is at about 12 weeks. And clearly, in about 3 months, or actually in close to about 4 to 5 months, there was almost complete resolution. What's interesting is, even from the first, the picture on the left upper corner to the right upper corner, within this period of about 3 to 4 weeks, the patient almost had immediate, not resolution, but significant improvement of his dysphagia. So we did this for about 6 months. We started spacing it out, continued to give him systemic therapy, and control this disease for almost about a year after that. But this is where I think the different ways of doing this, and I think the different ways in the context of where we would consider what's the best timing and what's the best way to do this and what's the safest way to do it. And I think some of the data that will be presented will show you that at least the safety data as it pertains to spray cryotherapy with this is certainly there. And the second thing is the efficacy, which we'll be talking about.
So typically in our practice, we are we think about it either as neoadjuvantly, or that is, if the patient has kind of a local disease and is going to undergo chemotherapy or chemotherapy radiation. When the patient first gets diagnosed, our gastroenterologist, when they do an EGD, and if they see that there is significant dysphagia, they usually end up getting one session when they set up for endoscopic ultrasound, or they will, if for any reason endoscopic ultrasound is not needed, they will call the patient pretty quickly back to get a session of cryoablation. Now, if the patient is going to undergo chemoradiation, there's typically a 2 weeks delay because radiation oncology needs to set up their dosimetry, fields and all of that. So in that 2 weeks delay, patient ends up getting another session usually. And so when they come to us, their dysphagia is already quite improved, and we can then go ahead and start chemotherapy radiation. So this is kind of the neoadjuvant approach which we are taking before we start systemic treatment for the patient. If the patient for some reason needs urgent chemotherapy or has very advanced disease or develops dysphagia while the patient is like Dr. Kunranda's case, where he was doing very well for many months and then or many years and then developed dysphagia but has been on systemic treatment. We've been doing it in between 2 treatment sessions, and I agreed with Dr. Kunranda. We kind of try to do it when we think the patient is not going to be neutropenic or thrombocytopenic, depending on which regimen they are on. Some are less myelosuppressive, so kind of right in the middle. Sometimes if they're getting FOLFOX, we will try to do it on day 10, which is an every 14-day treatment. I today had a patient who was on ramucirumab paclitaxel as 3rd-line treatment, and it is like a day 1, 8, 15 of a 28 days. So in the week he was off, which is the 4th week, we did his cryoablation, which he had it last week, and came this week to see me and get treatment tomorrow. So patients typically tolerate it very well. They may have a little bit of discomfort for a day or 2. We don't see any more significant side effects than other than mild discomfort for a day or 2. It doesn't interact much with chemotherapy. Our only concern is if patient is going to be thrombocytopenic or neutropenic, we want to avoid it during that time. So these are like, pre-chemotherapy or during chemotherapy, both ways quite safe.
So I think, Dr. Conrado, that was a great segue, because what I'm going to talk about a little bit is just kind of the role of cryotherapy in that neoadjuvant setting when the patient is first diagnosed with locally advanced esophageal cancer. So here's a gentleman. He's a fairly typical patient. He's a 71-year-old who was having dysphagia, had an endoscopy where they found esophageal adenocarcinoma. Then had a PET scan for staging, which found that there weren't any local lymph nodes or metastasis. So then he was referred to us for endoscopic ultrasound for local regional staging, for T staging and N staging. And something that's not unusual is that the tumor was obstructing to the point where we could get a gastroscope across, but couldn't get an EUS scope across. And usually that means that tumor is already at T3, which means the plan would be for the patient to get neoadjuvant therapy, which at the time was chemoradiation. I think now there's sort of a push towards a pure chemotherapy regimen plot. So this is a gentleman, we'd already been doing our trials, and the plan for this patient was, we'd been asked, can we do cryotherapy to kind of help with dysphagia? As you can see, he's having a hard time tolerating any food before he starts chemotherapy and radiation. And so I think there's some, practical questions that come up. Well, if you're going to do it in that setting, what scope and equipment do you use? And we've talked about that a little bit. The fact that you can use an XP scope if it's an obstructing tumor. But I think it's easier if it's not an obstructing tumor. It's easier to use a regular gastroscope just because you have a little more sort of maneuverability. But then there are a few other questions, how many times, and I think Dr. Bajwa touched on it a little bit, but how many sessions of cryotherapy do you administer? When do you bring the patient back for repeat cryo if you're going to do it before they start chemoradiation? And then when can they start neoadjuvant therapy once you've done cryotherapy? So I'll try to go into that a little bit. And so when we try to, how can we kind of use the data we do have to guide those decisions? So in a couple of studies, in one study we did, we found that the complete response rate with one session was 56%. And when we did 2 sessions of cryo, the complete response rate was 64%. So that kind of told us that maybe if we can, get 2 sessions in, it's better than just doing one. Um, and then we had actually done a dose frequency escalation trial that I'll talk about, where we gave up to 3 sessions. Actually, we gave up to 4. But what we found was that by the time the third session was during chemoradiation, so we improved their dysphagia and quality of life significantly with the first and the second sessions, but not with the third and not with the fourth session. So maybe 2 seems to be that magic number of cryotherapy sessions before neoadjuvant therapy. And so in terms of how frequently do it, well, partly in the neoadjuvant setting, you kind of want to do them quickly because you don't want to delay them getting their neoadjuvant therapy. But we actually have some guidance from the inoperable setting. So this is outside of the neoadjuvant setting, where we had a trial, multi-center trial, and some of us, myself included, were doing cryo every 4 weeks, and others were doing it, more intensively, which they defined as at least 2 sessions within 3 weeks. And again, what they found that was it was safe to do more frequent cryo, and in fact, dysphagia improved better if you did cryo more frequently, which again was defined as 2 sessions within 3 weeks. And then in several studies, when we've done cryo and held off for about 48 hours and done chemotherapy after that, that's been a pretty safe approach. And so kind of putting all of that together, so in the neoadjuvant setting, when they're first diagnosed, what we suggest is trying to get 2 sessions of cryo in the first 3 weeks, while they're getting staged, while they're getting worked up, while they're getting all their other appointments settled in. Ideally, if you do endoscopic ultrasound and cryo in your practice, you would do that first session of cryo during the staging EUS just to minimize the number of endoscopies. But there are centers where the person who does cryo is different from the person who does EUS, in which case it can be done as a separate session. The next session is ideally done 1 to 2 weeks later. And that can be a little bit of a challenge logistically. So I think ideally what you want to do is try and get both sessions scheduled, at the same time. So you're not running into, do you have an appointment in 2 weeks? Can you find something? And then really we've taken the approach of you can start when the oncologist asks us, when can you start neoadjuvant therapy? And our answer has usually been within 48 hours after the cryo. And that seems to have been, at least in our own experience, and then we've begun to publish that experience, a safe approach. Another question comes up, what do you do with their anticoagulants? So I think if they're just taking, some anticoagulant for CHA2DS2-VASc score of 2 and it's low risk, we'll still hold the anticoagulant, but we have several patients who have a history of DVT. I mean, cancer is a risk factor for thrombosis. They have a mechanical mitral valve. In those patients, we found that it's safe to do cryo in the setting of anticoagulation, so we won't hold the anticoagulation. And then in terms of, adverse events, it's not uncommon to get a little bit of chest discomfort soon after. Usually that gets better in a day or 2. And again, in the past, I used to give them sort of liquid opiates. I've pretty much moved completely away from opiates, so just some liquid Tylenol seems to be sufficient. And just kind of summarizing, some of the data, at least in this particular space, there've been 2 pilot prospective trials. In the first trial, we did 1 session of cryo before neoadjuvant therapy, and once we found that was safe and seemed to improve their symptoms, we did a dose frequency escalation trial where we gave up to 3 sessions before neoadjuvant. And again, with the 2 sessions of neoadjuvant, we found that both dysphagia and quality of life improved. No patient had any grade 3 toxicity. No patient needed an esophageal stent, and really only 10% of patients needed a feeding tube for feeding. And then one of the most exciting things was that one of the things that was, I won't say unexpected, but was kind of unanticipated with our first study was that we found that normally when we do neoadjuvant chemoradiation, at least in the CROSS trial, we expect a 25 to 30% complete response rate. Now in our small pilot study, we found that our complete response rate was 50 to 60%. And so we then did that dose frequency escalation trial where we really replicated those results. And then what we did was we took our patients who got both cryotherapy as well as chemoradiation and compared it to patients in our cancer registry who got chemoradiation alone. And what we found was that they did have, maybe had this anti-tumor immune response where they had increased tumor-infiltrating lymphocytes, cytotoxic T cells. So at least there's a signal that maybe neoadjuvant cryotherapy can stimulate sort of this anti-tumor immune response, and sort of quote unquote prime them for neoadjuvant therapy. Obviously, we need a lot more data to prove this, but the signal's there.
Okay, so we're going to get back over to the procedural techniques. There's already been one question about procedural technique as to how to approach a larger lesion, which Dr. Kothari, if you could talk about that. And additionally, Dr. Barber, Dr. Shah, all the interventionalists may want to comment on technique aspects that were not highlighted in the original case and video.
Yeah, so I think to answer the question first, we always like to go distal to proximal, and as Neil said in the chat box, we try to treat one 180 degree and the other 180 degree side of the lumen. If it is a really bulky tumor, sometimes we go up to 45 seconds. That is after you've seen the frost, you go on for 45 seconds. If it's a flatter tumor, I personally go to 30 seconds before you start thawing the lesion. Briefly talking about, and you move distal to proximal, and if it's a really long lesion, then you may want to do it in different sessions, the ablation. In terms of general techniques, we use the standard adult gastroscope for most cases if it can pass across the lesion. If not, you can use the XP scope, and we start with a distal spray and slowly move upwards. As Dr. Sharma showed, sometimes we use the clear cap. Again, if able, if the tumor is really friable and the cap you feel like is causing mucosal injury, then it's better to do away with the cap. Placement of the decompression tube is key. It is ideal. As we talked about it earlier, the gas quickly expands, and that's why you have to make sure that the decompression is going on and there is no kink in the decompression tube, and it's working adequately well. And we will go on the role of your nursing team, which is also important in these cases. 30-second applications per session is what we usually do. As I said, if it's a little bulkier tumor, we go up to 45 seconds, but usually most commonly we use 30-second applications per site. And the treatment every 1 to 4 weeks based on response. I know a lot of experts talked about their experience in terms of timing it with chemo, and you need a close collaboration with your oncologist, your radiation oncologist, medical oncologist to time it to be their therapy. So, patient is not getting delayed in any of their care. Larger tumors can require multiple sessions, as longer sessions of ablation if it's a really bulky lesion, or a reduction in the interval of the spray cryo. And the venting equipment is really important. That is, again, the cryogen delivery system and the venting equipment, and the use of the decompression tube. I personally use the 16 French for the most of my cases, because usually when these patients are coming with dysphagia, the lumen is really narrow, and you have very limited space after the decompression tube to maneuver your scope and get a good ablation of the site. Your nursing and tech team is very essential in these cases, and they actively have to monitor that the suction in the decompression tube is not kinked, especially as the scope gets very cold, and as the friction sets in between the scope and the decompression tube. And as you're actively spraying the cryogen, the nurse is actively massaging the abdomen to feel and make sure that it's remaining soft and it's not getting distended, or some of that would be signs of the gas accumulating, or even if any complications. So the nurse has to keep massaging and keep on feeling the belly as you are actively spraying the cryogen. And it's a gentle palpation during the cryogen, and with active feedback to the physician. So during the procedure, as I said, decompression tube across the G junction, start the suction prior to a cryotherapy. So you hit the suction, it's one tap, and then you hold down on the pedal to keep spraying cryo. As soon as you take your foot off, the spray stops, and you have to tap the pedal again to stop the suction. The absolute contraindications for doing cryotherapy, of course, if it's a really high-grade tumor that you cannot get the decompression tube down and it cannot be traversed, if there is a suspected or known perforation, and of course if the patient is unfit for anesthesia. So the main goal is that you have to be able to traverse the lesion and be able to get the decompression tube down. I've had one case where we've not been able to do that. Post-procedurally, again, you never discharge a patient with any kind of symptoms. Make sure, especially in recovery, I personally send them with liquids for 24 hours, soft foods for 2-3 days. They all go home on a prescription of Tylenol with codeine syrup. In case they have pain, usually this is a very well tolerated procedure, and patients almost every time say, I have the prescription from last time and I've not used it. We follow them in 2 to 4 weeks for their repeat ablation. We have a set of instructions that the patients are discharged with, and they know that the diet restrictions and stuff they're supposed to follow. These are some videos that are available. Again, they talk you through the steps, like Dr. Sharma showed very beautifully earlier, in terms of the steps of cryotherapy and the setup and all of those nuances.
Okay, so we'll get a little bit into building a practice and try to leave some time for some questions. So, Dr. Barber, maybe if you could lead this portion, and certainly comments for our medical oncologists. As we highlighted, it's really important to engage with your medical oncology colleagues when you approach these patients with esophageal cancer.
Yeah, thanks, Neil. Thanks for setting this all up, guys. So yeah, we implemented a cryotherapy program, I think about 7 years ago, maybe 8 years ago now. And when we started, it seemed like it was novel, but I would agree with you, it's not really novel at this point because we've been doing it for this long. And we started off just by increasing the knowledge that we possess the technology. And the way that we did that was by meeting with our medical oncologists, both individually and then attending tumor boards and explaining the therapy to our group, and then, letting everyone know that we had it. And we started treating their patients. And, just by maintaining open communication with the oncologists, we've been able to build a pretty robust program. There are weeks when I do a full day of cryotherapy, depending on, the scheduling of that. So in terms of, what my recommendations would be, I think is being available, answering your phone, giving people your phone number. As far as a fellow goes, when you land in practice, is something that I really hammer home with our fellows. It's that answer your phone and be a nice person. Just, don't be a jerk to people, call them back, return their calls. And all of a sudden, those cases start flowing in. You end up being really, really busy when it comes to starting a program. I think that's really the extent. I think tumor board is the main thing. So I would highly recommend, if especially for the fellows, if you're not attending your GI tumor boards, it's highly recommended for building a practice in general and getting your name out there. So in terms of how we monitor the patients and how frequently, I know there's been a lot of talk about how often are we bringing them back. I think 1 week early with bulky disease is ideal, but 2 weeks for us is kind of the standard, and that's just because of scheduling. It's really hard for us to schedule patients every week, but every other week seems to be pretty doable. So that's what I generally recommend. And really, we're just following their dysphagia scores, and if they're still symptomatic, then we continue to spray. There was a question asked earlier: how long do we continue? How do we know? Of all the things that we do in GI oncology, this is the one therapy that I'm fairly convinced that the patient actually will ask you for. So the patients really feel very good after the procedure, and I think that they're happy to come back and get more cryo because it increases their quality of life and their ability to eat with their families. In terms of implementation of the program on a system-based level, it is really, really important that when you're billing for this procedure, that you're billing just for the esophagoscopy and not for the EGD. So if you bill a 43229, the hospital reimbursement is somewhere about $3,600 for us, or kind of roughly in that area, and the catheter cost is about $2,000. So the hospital actually does okay on this procedure. If you bill a 43270, the reimbursement is around $2,000, and the hospital actually ends up eating a little bit of cost. So in terms of implementing a program on a system-based level, I think it's important to make sure that you're not costing the hospital a bunch of money, because then somebody's going to be tapping you on the shoulder and saying, hey, you're doing too much cryotherapy. In 7 or 8 years we've been doing it, we haven't had a single complaint from the hospital in terms of the cost. And I think this is really beneficial for the patient's quality of life, and also just for their ability to eat and feel like a normal human while they're going through these procedures.
So the final slide here, we talk about the key pillars of clinical practice implementation. And I think you've seen a lot of this highlighted. What's unique again about this aspect is having familiarity with the oncologic guidelines and then being engaged in multidisciplinary boards. I think, that's not typically addressed for general GI fellows, but certainly for interventional endoscopy fellows, it pops up and is very important, because the vast majority of your procedures will be oncologically related to a certain degree. So that includes EUS for ruling out cancer, staging cancer, so on, cholangioscopy for staging bile duct cancers, resection if it be ESD, et cetera, et cetera. So I think it's so important to be part of this team and engage in a team, as Dr. Barber and others have highlighted this evening. A lot of the other pieces, we've really tried to do a good job of trying to expose you to this technology as much as possible and understand its application in this disease state. I would open up to questions and ask if any of you have questions that you can engage all of us in. So I see a question from Mary, and it says, after cryo, then dilation for concern for perforation. I think I showed you a video example of one of my own cases of doing dilation. With that said, in our CPM, our clinical practice model, we've put in an advisory that this should be patients or people who have exposure or experience with performing cryoablation. You probably don't want to jump into the most complex cases early. That's for anything though. And I think all the other panelists would agree. It doesn't matter if that's ERCP, EUS, even just resecting polyps, you just don't want to jump into really big things in the beginning. I think there's a question also related to this. Can you dilate a stricture prior to doing spray? So, what we worry about with spray is, will that area expand rapidly enough into a defect that's in the deep submucosa, thereby translocating the nitrogen at a liquid, or when it turns to a gaseous state, into tissues that go outside the lumen? And so that's kind of the reason why people try not to do the dilation before. The other thing to consider is that if you dilate before, you're going against compliant tissue. It hasn't been manipulated to where the extracellular architecture has been frozen. Maybe other thoughts from Dr. Kathari, Dr. Shah, Dr. Barber around that?
Yeah, I totally agree. I don't do anything that I intentionally try not to violate the mucosa if at all possible. So I mean, there was a talk about, if there's a very friable tumor, even having the cap on there and really beating a tumor up, I try really hard not to do that before I spray. So I would recommend after for anything, biopsies, all of the, things of that sort.
Yeah, I'll say, all that being said, I completely agree. We have dilated, before I learned about using the XP scope, I used to actually dilate to try and get all my equipment down, as long as the tumor, you can't dilate a pinpoint tumor to the point where you can get your equipment down. But if it's just some gentle dilation, I have done that routinely and it's been safe. We haven't published on it. And then with regards to biopsies, actually our protocol was to biopsy before we did cryo, when we were looking at doing some of the immunologic analyses, and we had no adverse events doing that. So not saying you should do it and what's better, but we did it and we got away with it for many years.
Any additional comments on the immunotherapy in conjunction with cryo? Madhubal, Ravneet, have you guys had that?
Yeah, I think that's an excellent question. And I think that's the part that we're trying to explore. So I think the key part with cryoablation, right? I mean, like the biggest, when we think about just the mechanistic value, right? So when you talk about immune checkpoint inhibitors, these cause T cell exhaustion, and that by itself ends up causing this immune suppressed state and basically the lack of response per se. The key part with cryoablation is basically it induces antigens. So that's the reason why, to a certain degree, at least theoretically, and actually the Faber group has done an amazing job in terms of looking at this in animal models. And that's one thing that's definitely worthwhile and something that's continued to be explored in the context of using the cryoablation to basically release these tumor neoantigens and basically helping with some of these acquired resistance to immune checkpoint inhibitors. The second part of it, which although is interesting and intriguing, but we haven't seen a whole lot of, at least in human studies, we haven't seen a whole lot of, is this episcopal effect. We keep talking about it. There is some preclinical data that suggests that that seems to be the case, but then that's challenging. So the obvious question becomes, why? How about what's different between cryoablation versus using thermal ablation? And that goes back to the initial thing of, like, when you look at these antigens, they're proteins. So when you use heat, there is a chance that you'll denature these proteins, which doesn't happen, or at least in theory doesn't happen with cryoablation.
And then there was an additional question, and that question was around, balloon cryo. So I recently talked about this at the American Foregut Conference. I think the balloon cryo is honestly technically easier to use, right? And it doesn't have a capital cost because it's a disposable device. So it definitely has a place. Its place predominantly is in Barrett's esophagus. It's not really been utilized for esophageal cancer. And I think if we were to do those studies on it, there's a couple of things. One, esophageal cancer has a very uneven service. The balloon wants to go to its standard size and then deliver in a methodical manner, which makes part of what makes it easier to use and technically easier to acquire the skill set than doing spray cryotherapy. But the other big thing is to always think about dosimetry. And so, I talked about dosimetry tonight. The spray cryo balloon gets to about -85, -86 degrees Celsius. Spray cryotherapy is getting to -196 degrees Celsius. While you may get apoptosis with both, the depth of penetration of that apoptosis, we know, at least from animal models, and it was particularly done through the lung, but then later on done in luminal organs as well, that this is going to go to the deep submucosa, to the mid submucosa, depending on how you make that dosimetry, how often you bring them back, how long the spray was. So typically, no, not in this setting for esophageal cancer. Okay, another question. Thank you for the great lecture. Can cryo be used for tumor-related bleeding? And that's from Mohammed. Someone want to answer that?
Yeah, we have done some kind of refractory bleeding cases. I think radiation is the standard if somebody's truly bleeding, but if they've maxed out radiation, we have done some, I'd say, with kind of mixed results.
Is pretty much everyone using the 16 French decompression tube over the 20 French, or do some still use the 20? We can go around in a circle. So maybe we'll start with Shivangi.
I just use the 16 at this point.
Tilak?
We just got the 16s, so I think I will just be using the 16s. Now, there was an earlier iteration of the 16 French that was really floppy, but I think, and then I stopped using it because it was sort of kinking, but I think with the newer iteration, I anticipate we'll just be using the 16s.
Jeremy?
Yeah, same. I've been using the 16s all along, but I agree. I had one perforation with a 16 a couple of years ago when I had a fellow doing the case, and I think that the catheter kinked, and it happened very, very fast. So I think the updated CDT with the wire inside the tube itself is a much better decompression tube, and I highly recommend the 16. It gives you a lot more freedom to move around in the distal esophagus, especially if it's bulky tumor.
I preferentially go to the 16. Sometimes we have 20s there and we'll use it. So yeah, I think we're kind of all in the same boat. And then I'll ask this question. It's some prospective trials on neoadjuvant spray liquid therapy. So I think, Tilak, this is perfect for you.
Yeah, it's funny. We just had this discussion. We haven't started it, but there's a grant that we just wrote and a protocol we just wrote, and we'd certainly be happy to talk about it. But that one the one I'd like to do is kind of looking at FLOT and randomizing patients to get FLOT and cryo versus FLOT alone.
Okay, and another question on roll and recurrent GAVE. Jeremy, I think you and I have talked about this before. You do using it in GAVE?
We have done some cases with GAVE, and I have seen a response. So yeah, kind of similar to how I would use RFA for refractory GAVE for sure.
Okay, anyone else? Thoughts on refractory GAVE?
I'd say for GAVE, spray cryo is a little bit harder to use than, say, RFA or the cryo balloon. And so probably for GAVE, it wouldn't be my first line thing, just because it's a little more cumbersome, but it should work. So.
All right, I'll say a couple of comments. I want to hand it back over to Sri because we're about 5 minutes over time. So first and foremost, thank you to everyone for attending. We feel really strongly about this technology. I think having these types of multidisciplinary engagements, I've been getting a lot of energy from that. So working with the medical oncologist, working with surgical colleagues, because we don't work in a vacuum anymore. And I think we get trained in a vacuum, but we don't work in a vacuum. And then thank you to all of my KOLs. They put a lot of energy. They have a lot of expertise into the CPM. It's hard to get this many experts together and then yet alone design a CPM. And then finally, who I'm about to pass it to, thank you to Sri, because he's been the energy behind utilizing this model to create CPMs, EndoscopyNow, and is just a big proponent of education. So I'll hand it back to you, Sri.
Thank you. And thank you all for attending. Again, this doesn't end tonight. I think this is hopefully a beginning of an excitement. And as we said, this is just, one aspect in GI that's very innovative and promising. And we hope you really take it to heart. And everyone's available, and people want to, if you have questions, please reach out at any point. So thank you so much. And we hope everyone has a fantastic evening. Thank you.